This is actually a very timely subject. There have been a lot of developments of immune checkpoint inhibition within the myeloid space, and I think we are getting more new agents, and it's becoming more exciting. So traditionally, immune checkpoint inhibition in cancer has focused on what I would call the traditional pathways, which are CTLA-4 inhibition, PD-1, PD-L1 inhibition, and there are several approved agents, of course, in solid tumors. Those agents, such as ipilimumab and pembrolizumab, atezolizumab, durvalumab, have been used in trials of myeloid malignancies, both for MDS and acute myeloid leukemia. So far, the data with these agents have been largely mixed. We've seen some early signals, but in the randomized trial, the only actually randomized trial to date that has been reported, the Fusion trial, in which we randomized patients to receive either azacitidine or azacitidine with durvalumab. And that was for patients with acute myeloid leukemia who were older and unfit for intensive chemo, or for patients with high-risk MDS. There was no improvement in overall response rate, which was a primary endpoint of this study. And we did not also see differences in survival. Of course, that was disappointing, but I think this probably applies specifically to the use of durvalumab, which is an anti-PD-L1 inhibitor, and does not necessarily translate into other ways of immune checkpoint inhibition. However, I think it does highlight the importance of doing randomized studies, because when you go with single-arm studies, it's always difficult to fully understand the effect when you are doing a combination-based strategy, which is, I think, the way to go with immune checkpoint inhibition. Monotherapy does not generally work particularly well, except potentially in the post-transplant setting, where some data have suggested that using ipilimumab in the post-transplant setting, in the relapse setting, might help, especially with extramedullary relapses. I think a more interesting approach has been the development of also new immune checkpoint inhibitors, such as a TIM3 inhibitor. So this antibody called MPG453 or sabatolimab, this agent actually has been already shown in phase 1 data that has been reported in ASH 2019 and being updated in ASH 2020. To have some synergistic activity with hypomethylating agents for both acute myeloid leukemia and MDS. For example, the overall response rate in patients with high-risk MDS, and that was in combination with hypomethylating agents, was more than 60%, which I think is encouraging in the frontline setting. And there is ongoing studies with this agent. So TIM3 basically is an immune checkpoint inhibitor, basically a receptor that is expressed on T cells, but also on innate immune cells, such as macrophages and dendritic cells. And I think more interesting is that this TIM3 is also expressed in leukemia stem cells, and its inhibition has been shown to interfere with self-renewal by interference of the receptor interacting with its ligand, galectin-9, one of its ligands. So not only does it target immune activation, but also it works directly on the leukemia stem cells and the blast. Interestingly, this TIM3 is not seems to be expressed on normal hematopoietic stem cells. So you would think that the toxicity, the myelosuppression, would be lower with this agent. So now we have an ongoing randomized phase 2 trial in high-risk MDS in combination with azacitidine that has actually azacitidine or decitabine. They allowed both agents that has just completed accrual. And this is a randomized study. So I think it's going to give us a lot of answers about the clinical activity and the safety of this agent. But also there is a large registration style study called Mds Stimulus 2, which also is an advanced phase 3. This study is currently ongoing, and the goal is to look at overall survival. Also, the agent is being studied in combination with azacitidine and venetoclax, which has, aza and venetoclax have become standard of care for older unfit patients. So there is an ongoing study called Stimulus AML-1, which is looking at the triplet combination of sabatolimab with azacitidine and venetoclax in this patient population. It's a single-arm study, but it's a large phase 2 study that's international. And I think it's going to provide us a lot of data about the safety of the triplet, but also about early signs of the clinical activity. Another, I think, important immune checkpoint inhibitor currently being studied is Magrolimab, or the anti-CD47. And there's a number of other anti-CD47s that are being reported. The activity of this agent has been shown also in combination with azacitidine, with promising response rate and survival. So currently there's an ongoing phase 3 of this drug with azacitidine, with Magrolimab versus azacitidine in higher risk MDS in the frontline setting. But also in acute myeloid leukemia, and data from this combination with azacitidine has been presented in this ASH, or is being presented in ASH, where the combination basically has shown activity, and the survival seems to be better than what you would expect for patients who have TP53 mutations, which are patients who have the highest degree of unmet need currently among patients with acute myeloid leukemia. Also in that context, I think it's important to continue doing these randomized trials. I have led the introduction of 2 trials in collaboration with the NCI here in the US, the National Cancer Institute, with the Cancer Therapy Evaluation Program, CTEP, in which we are randomizing patients with acute myeloid leukemia if they are fit for intensive chemo to 7+3 with Pembro, an anti-PD-1 inhibitor, or if they are not fit for intensive chemo to azacitidine with Pembro versus azacitidine. And I think these randomized trials are not only important to understand the efficacy clinically of the combination, but also to understand at the biologic level what immune checkpoint activation is doing, and try to find predictors for patients who are likely to respond. So a lot of new developments. It's an area that is continuing to get more attention. More other immune checkpoint pathways are being targeted. There is one called LILRP4, a new agent called IO202. There is the TIGIT, there is the LAG3. So a number of agents, and I think this field is just going to continue to grow more and more.